It's a great privilege for me to chair this session. And the Saudi Society for Family and Community Medicine. And in fact, this is one of the continuous medical educations that we strive to allocate the special time and the special eminent prominent speakers that they can deliver a quality of information that sharpens our knowledge and exchange the experience in this kind of scientific events. And today we are going to talk about a very important topic that is related to herpes zoster. And when we talk about the disease, definitely we have to go through the vaccine. And before I start, I would like to set up the stage and pave the way by saying that in the humankind, there was 3 important inventions that changed the lifestyle and they change the landscape, and it protect, in fact, the global safety and health of people in the globe. One is the antibiotics inventions, and the other one is what? The vaccine. Insulin, yes. So we have the antibiotics, the insulin, and lastly, but not the least, the vaccine that have protected many populations. And we have been witnessing the global epidemic of COVID-19, and because of a grace of Allah subhanahu wa ta'ala, and then by the vaccine, which protected the community and safeguard the economy, which was hit badly by these epidemics. And of course, when we look into the populations in the Kingdom of Saudi Arabia that drive our healthcare system, towards certain modalities, towards prevention rather than intervention, from disease to health and from illness to wellness. And that's why in the year 2050, we are going to have and witness the doubling of our populations from 37 million to 74 millions. And moreover, we are going to witness a group of populations who are geriatrics above the age of 65. They are going to be predominantly appearing as healthcare consumers with all the comorbidities. And because of these, definitely we are going to have a challenge of having certain challenge to control disease. And of course, all of us, we know that 90 to 100% of all of us have been infected with the varicella zoster. And ultimately, all of us at the age of 50 and above, we are going to be a victim, God forbidden, by the herpes zoster and the shingles. So, ladies and gentlemen, I'm very proud today to have our eminent speakers, Dr. Wael Bajahmoum, Dr. Mohammed Samanoudi, and Dr. Mansour Khalaf, whom they are going to enrich our scientific event with a lot of information and updates about the shingles and its vaccine. So in order to save the time and not to go further, I would like to welcome our online and Zoom attended colleagues. So I would like to urge them to put their questions in the Q&A sessions. So at the end of the sessions, we'll be able to answer their questions. So first, I would like to introduce our colleague, Dr. Wael Bajahmoum. Dr. Wael is a consultant of infectious disease and head of the internal medicine departments of King Fahd General Hospital, Jeddah. He's also a clinical assistant professor of King Abdulaziz University Medical College, Rabigh. He got a master's degree and PhD in infectious disease and tropical medicine from University of Liverpool. Of course, he's a well-known figure, and I don't have to go further because it will take a long time, but definitely he's one of the figures in our medical community with his contribution to the presentation, to the lectures and training and educations and even research. So I would like to thank Dr. Wael for accepting our invitations, and his topic is going to shed a light on the shingles disease epidemiology and the burden. So Dr. Wael, the floor is yours. Thank you.
Thank you. Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me. Actually, the pleasure is all mine. I was trying to escape this in-person presentation because of my flu, but I failed miserably. I'm really happy to be here. So without any further ado, I would like to thank all of you to attend. I would like to thank Multaqa al-Khabarat. I would like to thank Galasco, all the hosts and all of you. Really my pleasure. So, yes. Just Dr. Ashraf was talking about this issue. We may notice in the last decade of life that number of deaths has been declining all over the year, especially for infectious causes. And these are really well noticed in the last 100 years. Major factor for that, public health sanitation. People start to know that being clean and washing and using basic sanitation efforts is good. Antibiotics, and I did not mention insulin because it is not an infectious cause, and then the vaccination. Always when I present, I like to show this man, Adrian Cockburn. This man, he's a British guy. Okay, all right, thank you. This is a British guy who was raised and born in England and then immigrated to US. He's a physician and then continued his education in US for infectious disease. He authored this book, which said the title of Evolution and Eradication of Infectious Disease. And this was the era when antibiotics came to the people, and they thought that we can eradicate all infectious disease. He was very optimistic, and I like that. Anyway, Oh, that's all right. So he traveled to US. Okay. All right. So, and he died because of his smoking, heart attack, not because of any infectious disease. As you can notice, his cigarette in his hand. Anyway, history of vaccination is an old history. It's not new history. You can see the timeline for vaccination since 1800 and above. People start the idea of vaccination up till now. And again, we have a lot of history of vaccination. Uh, why do we vaccinate? It's a very simple question, and people usually ask themselves, why do we do this? Why do we do that? So I believe we need to stop the spread of diseases as prevention. So, and build a good community with a very good immunity to prevent those diseases. Protect people who are too sick. All right? So, about 77 of children are fully vaccinated, which is really good, and we know that. But many adults, they are not aware that we have or vaccination for adult people. And this is a common mistake in most of the societies. So how vaccine works? Just simple idea to imitate an infection and let the immune system know that you have a triggering antigen or something looks like the infection itself, and then the immune system will come back with antibodies within the body to fight that antigen and go for a simple immunity. Vaccines prevent deaths, vaccines save money, vaccines are without doubt one of the best things we do have in the last 100 years. A lot of successful stories with vaccinations. Many diseases has been eradicated. 100% eradication of diseases because of simple vaccination. Okay. So individuals with impaired immune system, and those are who in need of having the vaccines rather than the healthy persons. We know that impaired immunity can be occurring because of either drugs, steroids, some medications, sometimes because of diseases, infection, HIV, and other things. So transplant medicine is also one of the growing medicines. So people are using medications such as chemotherapy. All these may lead for impaired immunity, decrease immune system of those individuals. So here comes the vaccine again and increase the importance of it. Those happy days, and this again from UK, when they found the gonorrhea can be vanished within 4 hours by using penicillin. I think this is not valid now, and everything is resistant now. So just to take a quick look about the incidence of herpes zoster and the post-herpetic neuralgia increased within the age. So within the age of 70, for example, it's almost double or triple the time, the number of the portion of the patients who are having the infections. So, and this makes logic. So by the time you're getting older, your immune system is getting down. So we have the two extremes, either when you are a child, below 2 years of old, or if you are older than 60 or 70 years of old. Sorry. So, what is shingles? Risk factor for shingles and vaccination. It's simply viral infection of the nerve cells and the surrounding skin, and this is how it looks under the microscope. It has a natural history of pre-dormal phase, and then acute phase, and then subacute phase, and then the post-herpetic neuralgia. I will come in detail of this in this timeline of the infection. So after person recovers from chickenpox infection caused by the varicella zoster virus, the virus remains dominant in the nerve cells until it catches a time where the immune system goes down. And it is almost similar to the whole story of the infections in this life. Like TB, when it gets a chance, again, you get infection while you're a child. When you get older, when the infection gets a chance, when your immune system is going down, it jumps up and fight with, and then again against your immunity. So reactivation of dormant viral lead to the clinical manifestation of shingles. Reactivation can be associated with older age, and this make logic. Sometimes malignancies and chemotherapies, and again, immunosuppression play a very important role in that. Some pictures, clinical findings, you will find the shape of the neuralgia is taking the shape of the neurons everywhere, and it will cause very severe pain. I will not go in through detail. So prenormal phase, the first stage of shingles may include abdominal and skin sensation, abnormal sensation, sorry, and pain also affect the area of the skin. There might be headache, feeling generally unwell, photophobia, malaise, and to some extent fever, which is not common symptom. About 100% of people above 50 years of old get the infection earlier in their life. Now almost all of us had it before, and just been mentioned by my colleague here. So it's a matter of time. Whenever you have bad immunity, you will get it. This is the message I would like to deliver. So all divisions of neuralgia is there: ophthalmic, thoracic, and thoracic, and all over. I will come in detail about the common areas of infection or dermal herpetic lesions. A predermal illness is experienced by about 80% of people. So you will feel that, you will have the infection, you will know that you have it, and it is almost there in about 80% of people, and it will be there for about 72 hours, 72 hours of the rash appears. So you will know that you have it. Herpes zoster rash follows unilateral distribution, usually one side, and as you can see here, I hope I will not turn off, yes. It is not appearing. Anyway, you can see the different distribution of the nerves and where it may affect more commonly in the thoracic, about 56%, and then the other areas can be affected as it goes. The rash often cause intense pain, itching, and tingling, picking, numbness sensation in the area of the affected nerve. And Allah la yawarikum al-alam, it's very bad, painful. If you see one patient of old age patient come to you in your clinic with that pain, you would know what I mean. It's really very bad. It's not easy to find someone who's old crying because of the pain. And believe me, it's really bad. The rash forms blisters that typically scab over 7 to 10 days, and then eventually clears within 2 to 4 weeks. So this is the natural history of the disease. Then some ideas which really describe how painful it is and how bad it is. Some people are describing it as very bad, as even worse than the cancer feeling. So rash of fluid filled with blisters develop after a few days and commonly occurs either on one side of the face or the body, usually within the distribution of the dermatome and an area of the skin around that area. So this is just to describe the clinical look. The rashes often cause intense pain and itching and tingling, making sensation, as I mentioned earlier. All right. So it's aimed to prevent. The idea of the vaccine is to prevent, and the prevention always better than cure, as we said. So whenever have vaccination is for prevention, and prevention is better than cure. So it is therefore a prevention vaccination, not a therapeutic one. This includes patients with HIV infection. rheumatoid arthritis, SLE, chronic inflammatory bowel diseases, just name it, whatever may cause decrease of your immunity, those have a better chance of getting the infection. For many patients, herpes zoster can lead to serious complications, and you can go through it. Most important ones in the pain is the neuralgia and the severe pain they have. So we have to think, why we need that? Why do we vaccinate adults? I said, just imagine about 50,000 cases, 50,000, I'm not, this is a very big number, 50,000 cases of shingles occur in people aged above 70 years of old in England and Wales. About those patients, about 14,000 develop very painful, long-standing, long-lasting condition called post-herpetic neuralgia. So if we have 50,000 people getting that infection, about 14,000 of them will have the pain, and about 1,400 cases of shingles will be hospitalized. So again, we are talking about money, we are talking about economy, we are talking about pain, we are talking about patients' management. Okay, so about 1,400 will be hospitalized, and you know that will cost a lot. 1 in 1,000 cases of shingles, people 70 years and older may die. And yeah, I mean, death is one of the complications. So epidemiology of shingles in England and Wales, as we can see, as we go older, as the number is increasing. So, and that makes sense. Anyways, always think about it's viral infection. This is just to refresh. Okay. The most common complication of shingles is severe pain where the shingles and the rash is. There is no treatment or cure of that pain. And here comes the importance of the vaccine. We have no treatment, so the best way is to prevent it. Okay. Shingles may also lead to serious complications involving the eye. Very rarely, shingles can also lead to pneumonia, hearing problems, blindness, brain inflammation like encephalitis, or even death, as I mentioned earlier. So as with vaccination reaction may occur in some cases, and they also arise because of the immune system activated and produce antibodies. The same idea in generally about the vaccines. If a vaccination reaction occurs, usually it lasts only for 1 to 3 days maximum. Typical symptoms include pain, redness, and the stuff we know about the vaccine. So what do we need to know about the vaccine? It's about that infection, herpes zoster infection. It is increasing by the age. So patients who are getting older, they have more chance of getting the complication of herpes zoster, and then it can cause intense, severe, intolerable pain, which can be annoying and can be one of the worst nightmare of patients. Then depleting to daily life of patients. They cannot even tolerate it to the point that they cannot perform their normal life, may develop serious complications, including the pain and even sometimes rare complication, including pneumonia and death sometimes. So vaccination will save money, vaccination will prevent the disease, and it is recommended for patients who are above 50 years and old, and it is really one of the good things we need to have in the future. I think that would be my last slide. Thank you very much, Dr. Ashraf. Thank you.
Thank you so much, Dr. Wael, for this wonderful, elegant presentations. You took us in a journey to identify the issues regarding the herpes zoster and the importance of vaccination, especially for the highly specific, highly risk group. So with this, ladies and gentlemen, colleagues, I would like to move, for the sake of time, for the next speaker, who is also a well-known speaker, Dr. Muhammad Samanoudi. He's a consultant in internal medicine in infectious disease, transplantation, infectious disease, King Fahd Armed Forces Hospitals in Jeddah here. And he's assistant professor, Department of Medicine, Faculty of Medicine, Al-Qura University in Mecca. He had a fellowship of transplantation, infectious disease, University of Texas in Houston. And he had the American Board of Internal Medicine Infectious Disease certifications, which was followed by a fellowship of the Infectious Disease University of Texas as well. Dr. Muhammad is a well-known figure, in fact, in delivering a state-of-art presentations, and he had a lot of contributions for the medical community with a lot of research and publications. So we are really privileged to have Dr. Muhammad with us today. So he's going to talk about the life course vaccinations. How is the immunity of geriatric populations weans and subject those people to the risk of the infection, especially herpes zoster. So on your behalf, or ladies and gentlemen, I would like to welcome Dr. Muhammad to the stage. And thank you for accepting our invitations. You have a screen here, you can have a look at it.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Ashraf. Thank you for everyone for inviting me here, and I hope you will enjoy my lecture. Okay, so today I'm going to talk about mainly about how the immune system fight infection and how the aging process responsible about getting infection in the elderly people. Then at the end we'll talk about the herpes zoster vaccines in a brief way. So our outlines today is going to be immunology, indications for the vaccines, types of vaccines, efficacy, side effects, contraindications, and we'll talk about some special situations about the zoster vaccine. So regarding immunology, so let's go back a little bit in the dark decades during the medical school. So immunology part, so if you start with, if any foreign body comes inside the body, so we'll have the first defense is going to be the innate immunity. Usually the first line is going to be the phagocytes. The main cells is going to be the macrophages and the dendritic cells. Usually engulf that foreign body. Let's say infection. So infection inside our body, it's engulfed by, let's say, phagocytes, macrophage. It's gonna do a phagocytosis inside that macrophage. But if the load of infection is high, that macrophage or the phagocytes will ask for help, right? So the main help is gonna be the adaptive immunity. So what is the adaptive immunity? So it will have, that phagocytes usually have some, like a feature called antigen presenting cell, APC. So that's gonna present that cells to the main defensive cell called CD4 or T helper 1. So once it show it to the T helper 1 or to the CD4, so right away the CD4 will respond to that things, and they will attach to each other, and that attachment will allow more cytokines to be released, and that will do two things. Number one, it will activate the humoral immunity. As you see, the B cells, the antibodies, the plasma cell, then B cell, then antibodies. This is, we call it humoral immunity. Or it will activate the cell-mediated immunity, which is mediated by cytotoxic T cell, which is CD8. So this is just like back to the basic immunology, and that will help us what's gonna happen in the elderly people. So in the elderly people, both things gonna be affected. The innate immunity, the first line, and the adaptive immunity. So as you see, the phagocyte capacity is gonna be impaired, and that antigen presenting cells is gonna be impaired. And that will result on that the affinity and of the antibody response is gonna be diminished, and also the T cell, the receptors on the T cells that always respond about getting the signals is going to be diminished as well. So in elderly people, the two basic things in immunology is going to be affected: the innate, the first line, and the adaptive immunity. And this is usually happen after age of 50. So why should we get immunized against herpes zoster? To reduce the risk of developing the herpes zoster or the reactivation, either getting a new herpes zoster or the reactivation. And to reduce the post-herpetic neuralgia, as Dr. Weil mentioned that in details. And to reduce the risk of varicella zoster complications, such as encephalitis, vasculitis, especially in immunocompromised population, including elderly people. So it's very important to get vaccinated to prevent these three major things. I think we need to go back. Okay, so what are the types of varicella zoster vaccines? We have zoster vaccine live. The major name is Zostavax, usually administered as subcutaneous, as all live attenuated vaccine injected. So it's 0.65 ml as a single dose. But look at the efficacy. It's like 51%. And that's the only thing what we had before the new recombinant zoster vaccine. And no longer, now in the United States, no longer available there by the date of November 18th, 2020. But still can be an option as an alternative option in immunocompetent patients. The protection wanes significantly after about 8 years. So imagine that. After 8 years, almost Zostavax effectiveness is almost 0%. And that's why what's promoted that Shingrix vaccine to come nowadays. And we'll talk about the efficacy now about the recombinant zoster vaccine. So recombinant zoster vaccine is administered as intramuscular because all the components are like dead virus. So majority of the dead vaccines or the dead particle vaccine injected as intramuscular. So usually the first dose will be given, followed by the second dose 2 to 6 months. So usually 2 to 6 months, but in immunocompromised patients, we prefer to go a little bit like on the lower limit. Like we prefer 2 months is enough right away to give it so they can have the maximum effectiveness of the vaccine. Recommended in immunocompetent adults in age of 50 and older, and in immunocompromised patient in age of 19 and older. And this is new. Remember, the Zostavax was 60, and now it's 50 in immunocompetent and 19 in immunocompromised. Currently, it's a preferred vaccine against herpes zoster. Efficacy. So look at many trials assess the efficacy of the recombinant zoster vaccine. Look at them. It's like 96.6 in adult between age of 50 and 59, 97.4 between age of 60 and 69, and 91 between in people above age of 70. So majority of them is like above 90%, which is great compared to the Zostavax. And even they compared it to the hematological malignancy, like 87% in patients with hematological malignancies, and 90% in patients with immune-mediated diseases, but they are not taking immunosuppressive medications. So the efficacy is great. So that's why we are moving toward that this is the preferred herpes zoster vaccine. So if we look at the side effects, about 1 in 10 of the adults who received the recombinant zoster vaccine reported injection site symptoms such as pain, redness, swelling. Also about 1 in 10 reported systemic reactions such as myalgia, fatigue, headache, shivering, fever, like all kinds of systemic symptoms. And severe allergic reaction was very rare in the trials. Okay, so the durability of protection. Remember we said about 8 years with the Zostavax or the live attenuated vaccine, everything is gone. But in herpes, in recombinant zoster vaccines, the immune response is effective about 84 to 91% up, like through 9 years of follow-up. The maximum they did 9 years, and the effectiveness was around 90% compared to 0. So that's why we moved to it without any doubt. Sorry. Okay, contraindications. So prior IgE-mediated reaction, so if a patient had anaphylaxis from the first dose, so this is a contraindication to give the second dose. And this is the question that we usually get asked. Well, how about the pregnant people? So usually recombinant zoster vaccine should be avoided during pregnancy because it has not been studied. And the ACIP, the Advisory Committee on Immunization Practice, said that, sorry, I don't know why it's moving very fast. Okay, that after the delivery, you can give it regardless the breastfeeding, okay, to whom that zoster vaccine is indicated. Like for example, after delivery, the patient developed let's say Hodgkin lymphoma and now on chemotherapy, and you need to make sure that they don't develop herpes zoster reactivation. For those people, you can give them the vaccine regardless to the breastfeeding status. I don't know what's going on here, but okay, so we have a special situation with the recombinant zoster vaccine that we are usually asked about it in the clinic. So they said, doctor, I already took the Zostavax. Should I take the recombinant zoster vaccine? So the answer is yes. You can take the recombinant zoster vaccine, and the ACIP recommends the first dose can be given with the minimum time to wait 8 weeks. And honestly, I prefer, because with all that what we studied about, like the 8 years duration of protection, so recombinant vaccine should be given even if the patient received the Zostavax. How about, doctor, I have a herpes zoster infection, a recent herpes zoster infection. Can I take it? So in acute setting, no. If the patient has acute herpes zoster, acute shingles right now, should those people take recombinant zoster vaccine? The answer is no. But they can take it. The ACIP recommends to take it approximately 1 year, since already the active zoster will give them that immunization against zoster at least for a year. So 1 year, they recommend to wait for 1 year, then to take the recombinant zoster vaccine. Okay, so the other question also in the clinic, like, can I take it with other vaccines? So the ACIP recommends, yes, you can take it, but in a different anatomical site. And nowadays, can I take it with COVID? The answer also yes. Right. Now, alhamdulillah, in our kingdom, they implemented the recombinant zoster vaccines in the whole kingdom, and these are the primary care centers that they offer the recombinant zoster vaccines for free, alhamdulillah. And I encourage everyone who met the indication to receive the recombinant zoster vaccine to take it, because of what we have been saying. Okay? Here is end of my talk, and thank you.
Thank you so much, Dr. Muhammad, for this elegant presentation, which was precise and informative. Now we will move to the third speaker, Dr. Mansour Khalaf. Well known, Dr. Mansour Khalaf, he's a registered pharmacist with a master's degree in public health from Denmark. has a diploma in infection control from USA, a member of the Canadian Public Health Association. He has a lot of publications and he has a lot of contributions in the research field, especially with a special focus on vaccinations. So his presentation is going to be about the Shingrix vaccine, and this is the most important part for us to know more details about the vaccine. So I will leave the floor for Dr. Mansour. Please.
طيب السلام عليكم ورحمة الله وبركاته. Thank you very much everybody for being here tonight, and I wish that my presentation will be smooth and we can really gain a lot from that. In fact, this is about today presentation, so shingles vaccination at risk adults. I don't know, this one should move. Okay, so this is about me. Thank you very much, Dr. Ashraf, for presenting me. For disclaimer, I'm a healthcare provider, and I'm also a GSK medical affair employee. Okay, so let's go and look at the Shingrix, or the shingle vaccine, recombinant zoster vaccine. Well, the vaccine itself, it is not actually a live attenuated. It is not a virus itself, but however, it is a recombinant one. What do I mean by recombinant? So they look at the virus, at the envelope of the virus, and they found different glycoprotein. And out of those glycoproteins, one of them was available as an abundant. Large number of it is available in the envelope. They took this one, which is called the glycoprotein E, and they have manufactured it in the Chinese, this animal itself, and they made the antigen, which is the glycoprotein E. Not only this, so this is made in something called the recombinant, so this is one type of vaccine manufacturing or production. But per se, the glycoprotein E is not immunogenic. So it does not actually give the enough immunity that is required. Number one, actually, important thing whenever that we produce or manufacture vaccination or develop a vaccine, it's not an efficacy, it is the safety. Because he or she, they are a healthy individual. So with regard to this, they try to reduce the number of side effects developed after vaccination. The antigen itself is not immunogenic, as we are expecting, as the natural virus. So what they have did, they have added something called adjuvant. So this is the adjuvant system that on the right side of the screen. So the adjuvant system, which is the AS01B, it's made of two things. Number one, it's called the MPL. The second one, it's coming from a tree or plant that's available in Latin America. So they mix it both together, and it gives very good, actually, result, as I will show you right now. So number one, it's a glycoprotein E, which is found as an abundant in the envelope of the virus. And this is the most important thing. And they found that this is responsible for the glycoprotein responsible for replication and the cell transfer of the virus itself and the production of it. So it's responsible for the pathogenesis of the virus. Okay, well, this is really maybe illustrating why we have added the adjuvant. I have mentioned something important related to the tolerability or side effects. So the native pathogen, it will give a good result. It's very high, actually, as in terms of immunogenicity, but however, again, side effects will be very high. However, if we go down to the live attenuated, I mean, it's still live, like, for example, the oral polio and rotavirus vaccine, which is live attenuated. You found that, and also the varicella virus or the MMR virus. All of those are live attenuated. So we found that they have a good, relatively good immunogenicity and lesser side effects compared to the native pathogen. Until we reach actually to the recombinant, where the immunogenicity is less than by far of the native pathogen. However, the side effects is very low. But when we add the adjuvant, what we have seen here, when we add the adjuvant, the immunogenicity increased dramatically, reaching similar exactly to the native pathogen, but however with a very low side effect. So this is why we have added the adjuvant. And we have seen this one. It's not just in this product or in the recombinant Zoster vaccine, but it has been added in other vaccines. For example, in the cervical cancer vaccine, HPV vaccine, it has been added to the flu vaccination, like H1N1 and other vaccines available currently right now. It has this kind of what's called adjuvant. In Arabic, we call it مساعد مولد مضاد. So it is something additive or مستضاد. Different type of adjuvant. Why I'm concentrating on adjuvant? Because a lot of vaccines is coming on the future and on the way, which has this kind of system. Adjuvant added to the antigen in order to increase the immunogenicity and reduce the side effect. So as you can see here, HPV vaccine, one of them, is, especially that one used in hemodialysis, the HPV, pandemic influenza, malaria, TB, HIV, Zoster, of course, this one, and other vaccines that is coming on the way. Okay, so I've just given a hint about the antigen as well as on the adjuvant, and how both of them, they are really needed in order to develop the response that is required. Okay, let's go now and discuss something related to the efficacy. Efficacy, not effectiveness. So I'm talking about efficacy, which has been done through randomized, observed, blind, placebo-controlled, multi-center, multinational studies in North America, in Europe, Latin America, and Asia Pacific. So this is the studies that was under, it's controlled studies. Okay, so there was two studies. The first one was called ZOE 50. This is the first one, and the other one is ZOE 70. What happened in ZOE 50 and ZOE 70? So why we call it 50 and 70? Because the age group included in this study, the ZOE 50 was 50 years and above. The other one was 70 plus. What they were looking at, they were looking at the efficacy itself. Efficacy means it is under controlled conditions. Effectiveness, it is whenever that you send the vaccine to the community. So whether they're taking 1 dose, 2 doses, and this is the result of whether it is the result of studies or just it is in the schedule right now and everybody is taking it, including herd immunity, etc. So dosing schedule was used. It was 0.5 ml at interval of 0 currently, I mean at now, and 2 months later on. What they were measuring, so the primary objective was post-herpetic neuralgia efficacy in persons above 70 years old, and herpes zoster efficacy in persons above 70 years old as well as. What was the number? This is the most important. It was a large number of enrolled patients. So here in ZOE 50, it was more than 16,000, and in ZOE 70, more than 14,000 individuals. What was the result? The previous speaker was talking about, he given some hints about, the result of the vaccine itself, efficacy, and here it is actually. Above 50, in ZOE 50, it was 97.2%, reaching 97.9% in more than 70 years old. However, in both of them, vaccine efficacy was reaching in ZOE 50 and ZOE 70, and above 70 years old, 91.3, and reaching for those above 80 years old, 91.4. So it was above 90 in general, 90% efficacy. And this is really considered to be a great result to the vaccine. Okay, so by preventing the shingles and What happens actually reduce the risk of post-herpetic neuralgia. It's very well known actually. Almost 1/3 of those affected by the herpes zoster, they suffer, or 20%, they suffer from post-herpetic neuralgia, which is a long pain and could reach actually sometimes for a year or something like that. So this kind of, and other complication, of course, like endocarditis, etc. However, here they were more concentrating on post-herpetic neuralgia. And post-herpetic neuralgia was reaching 91.2% efficacy and 88 on those above 70 years old. And also the other complication and those above 50, 93.7, and above 70 was 91.6%. So again, in other side, complication was achieved, was reduced dramatically. Okay, how long it will, the efficacy of this vaccine could last, and this is really very important. In different studies, it shows that it could last to up to 7.1 years, but however, currently, the studies that is showing around 10 years since it has been launched, so they are taking all the studies and patients who have been using it since the launch until now, and that is in US in particular, and it reached more than almost 10 years efficacy. Sustained efficacy against herpes zoster in adults 50 were at least 7 years, but however, it's extended up to, found it right now, is around 10 years old and onward. I mentioned at the beginning that any vaccine, whenever that we produce any vaccine, number one, we think about what? We think about safety. So safety was really a major thing, especially we are talking about, you know, an old person, especially above 80 or 70, as well as actually you're talking about, you know, a healthy individual. So solicited injection site reaction reported up to 7 days post-vaccination. And they were looking at including grade 3. The most, common side effect was there between all different age group was pain. Pain was the most common side effect. However, this pain was not lasting for a long period of time. It actually disappeared within 3 days. So that was number one. Pain, redness, swelling. So this is the normal one. However, this was really the most apparent one, but again, it goes within 3 days. The second one is systematic reaction, like for example, fatigue, fever, headache, myalgia, shivering. And as you can see again, so it was there and it was reported with a different percentage, reaching 45%, for example, in fatigue, myalgia, 46%. But again, very important thing that I have to mention is 2 days or less. So it doesn't last for a long period of time. This is really important, in which that they have measured the serious adverse events and fatal adverse events, and this was really something important to mention here. What they found that serious adverse events was quite similar to placebo in those studies, ZOE 50, ZOE 70, quite similar to placebo in both, whether it is serious adverse event or fatal adverse events. How we can implement Shingrix or shingle vaccine in RSV in practice. Very important, I have been asked this question a lot. Every time, whenever that I go and present, a lot of people asking me this one. And even the Minister of Health, when we have launched it, they have asking me this one every time I met them. They said, Mansour, can we use it only 1 dose? In fact, the answer is no, because we have not conducted a study for 1 dose. There was no study, single study being published showing efficacy after 1 dose, nothing at all. Also in this study, they have shown something very important, that after second dose, the immunogenicity increased by 3-fold. So this is very important. We don't need actually to go into 1 dose and then we see a failure. So 2 doses is the most important thing, and we need to give it 2 doses, in 2 doses, whether it is after 2 months or 6 months. So the 0 and 2 month is the most important thing, and we need to give it. We should not really allow patient or vaccinee to skip the second dose. So this is the number one. Number two, it is there is 2 vials inside each box, and one of them is a lyophilized, which is the glycoprotein E, which is the antigen itself. The second one is the liquid, which is the adjuvant, as I mentioned. So it has to be reconstituted. Whenever that is reconstituted, this is the nurse actually, and tomorrow there will be another session for the nurses, and it's very important that whenever that they have after reconstitution, should it be kept outside, should be kept in fridge, do not freeze, and within 6 hours they have to use it. And very important, it has to be used intramuscular, not subcutaneous, of course not intradermal, and not intravenous. So intramuscular is the most is the recommended site. Can be used with the other vaccines, yes. Unfortunately, actually, I have an experience when I was going actually to take my shot for RSV. The nurse told me you cannot, and I was planning to have the influenza, seasonal influenza vaccine, and she said, no, you cannot. And I was really astonished. I said, no, I can get it. She said, no, you cannot get it. And she didn't give it to me. She insisted not to give it to me, despite that this is really very important. We are talking about an adult, okay? So an adult, so I might not really come back again. I mean, it will take me some time until I come back again. It's not a pediatric vaccine, so this is really very important from logistic perspective. Tdap vaccine is again one of those vaccines that has been studied with, and pneumococcal, of course, polysaccharide vaccine, pneumococcal vaccine 23. Where it has been registered and used around the world in different countries around the world, as you can see, and one of them is, of course, Saudi Arabia. It has been registered, and now it's available in government, in institution, as well as in primary centers and in private in some institutions. In summary, and this is my last slide, we knew that this product has been made from glycoprotein E together with an adjuvant has been added to it in order to enhance the efficacy and reduce the side effects. What we knew, again, it is indicated for vaccinees or individuals above 50 years of age, as well as immunocompromised from 18 years and above. What we knew, again, that efficacy reached more than 90% in both groups, whether it is 90, whether 50 years old or above. And we have seen how we can use it. It's an intramuscular vaccine. It should be reconstituted and should be given in 2 doses. Thank you much, really. And thank you much, Dr. Ashraf. Thank you.
Thank you so much, Dr. Mansour, for these presentations. And coming to the end of this session, I would like to invite our guest speaker to be on the stage so we can receive the Q&A questions and we conduct the Q&A session. In fact, we will start as usual by giving the privilege for the attendees physically. So Dr. Abdul Hamid, you are the first. Please go ahead.
Thank you, Dr. Ashraf. Thank you for our speakers. Dr. Khalaf, after giving the 2 doses, is there a place for a booster after 8 years or 10 years, once the durability is only till now 8 to 10 years?
Well, thank you very much, Doctor. Actually, until now, no, nothing. So we haven't really studied this one, but until now, there is no recommendation for booster dose. Yeah, thank you.
Okay, thank you. Any more questions here? Dr. Hashim, you have a lot of questions. I can see it in your eyes. Yes. All right, okay. So Dr. Wa'il Bajahoum, he apologized because he's not feeling well, so we are missing one of them. In fact, there was questions came from the audience. Can the one who got the shingles can receive the vaccine? And it was stated clearly by you, Dr. Muhammad, the recommendation is after 1 year. But in fact, there is another school of thought and another school of practice says that after the disappearance of the rash and the complete recovery of the shingles, you can give the vaccine as soon as the recovery takes place. So what's your comment?
So I think we were like an immunocompromised patient after resolution of the herpes zoster. We were, yes, giving them the vaccine even before the 1 year. But in immunocompetent patients, as per the ACIP, it's better to wait for 1 year.
1 year.
So yes, I think with immunocompromised patients, it's better to give it like once the infection, the active symptoms of infection, that's what we were giving based on expert opinions, not based on the ACIP recommendations.
طيب Dr. Mansour, is it a lifetime immunity by the 2 doses? Do you think that this good enough for anyone to
Yeah.
have to develop this kind of long-term immunity? Lifetime?
Well, thank you very much, Doctor. Actually, we believe that until now, actually, we will follow whatever that has been published. So publications show that it's 10 years. We could really extend this, or it could be really extended later on, but this is really something, it's on the hand of the practice itself. So whenever that we have new data, published data, we will announce that this is really live or not.
Okay, thank you. In fact, there is one of the questions that came, which is really very interesting. What is the measures can be taken to prevent post-herpetic neuralgia? Is the vaccine has any role in this to reduce or to subside the intensity of the pain of the patients?
So yes, that is correct, and I mentioned it like in the indication why we need to get the vaccine. Actually, this concept we found it in many vaccines, like for example, influenza vaccine. So the protection against influenza vaccine is like about 60%.
Yeah.
But what is the most advantage from that vaccine is to prevent the complication, is more than 90% prevent the ARDS, the influenza vaccine. So that's the most important aim to get the influenza vaccine. For example, COVID vaccine, we are seeing people that are hospitalized in the ICU, they are all not vaccinated, and we are seeing the evidence of vaccinations that they will not be even admitted. The same thing here. The zoster vaccine, and mainly the recombinant zoster vaccine, it decreases the complications and it decreases the main burden of the herpes zoster, which is post-herpetic neuralgia.
Okay. Another question, I think it's also related to the treatment of post-herpetic neuralgia. What are the treatments? In fact, we come across these kind of issues in our primary care and even in family medicine. And according to the guidelines, we use the first-line medications, which is pregabalin, gabapentin, as the first dose. But still, there is a trial for tricyclic antidepressant and duloxetine, which works very well. But most of the neuropathic pain has to be combined together in order to achieve the remission of the pain, which is very intensive pain in terms of burning sensation, pins and needles, tingling sensations, and so forth. And that's why we, there are certain trials demonstrate that alternative medicines or alternative therapies like alpha-lipoic acids and L-carnitine can be used as well. But however, whatever we do will just reduce the pain by 30 to 50%. And the other 50% will be the continuous suffer for the patient lifelong. So this demonstrates how hard is the impact on the quality of life of those patients who are not receiving the vaccine and not getting protected because they are at risk. And I think it's very important point you mentioned, Dr. Mansour, which wasn't very clear to anyone, and even for me as well, that the vaccine is indicated for 18 years and above. It's not only 50 years and above. 18 years with the risk of comorbidities or immune-compromised patients. So we have enlarged the scope of the populations that are getting indicated to have these vaccines. Yes, any comment on this?
Well, yeah, thank you very much, really. In fact, that with regards to the immunocompromised, this is really very, very important. We thought that immunocompromised patients, they are at a greater risk of developing herpes zoster. And reaching this age, which is 18, number one, it is very important to protect those from it. We have to, again, to observe their status, and this is, we leave it with the hands of the treating physician. We should look, for example, HIV, we should look at the CD4, for example, before we give the vaccine in order to get the response, as well as actually for any other procedures that patients undergoing, especially for the immunocompromised. Sometimes we consider, of course, the diabetic as immunocompromised. So all of those are of the groups that we need to protect. And we reach, I mean, as I said, 18 years and above, it's one of the important things that we need to consider.
Yeah.
And I think in Saudi Arabia we have, I mean, substantial number of patients immunocompromised that needs to be protected from herpes, especially if we know that almost 99% of us, they have contracted chickenpox during childhood.
Yes.
99% almost that we have exposed to it. So it's relying on our dorsal ganglia. It's waiting there. Whenever that our immunity will go down, so this virus will be reactivated and cause a herpes zoster.
Okay, thank you so much. I think it's, any comment, Doctor? Yeah.
Just I would like to share like a very quick thing. I just had a patient today in my clinic who had a herpes zoster infection after getting a methylprednisolone for MS exacerbation.
Yes.
So the reason for referral just for the management, but I encourage everyone to open that discussion of the vaccination, because he mentioned that he's gonna receive immunotherapy soon. So if you just treat the herpes zoster and let the patient go, he will come to you maybe in a very bad situation with a complication such as encephalitis or vasculitis. So right away I told him, like, now we are done with infection, we need to get vaccinated with the shingles as soon as possible, and I gave him the places that they offer the shingles vaccine. So that's actually my message to you.
Yeah, this is clear. Mr. Hassan, here you have a comment. Please go ahead.
مساء الخير وشكرا على كل البرامج اللي بتقدموها لنا. I'm sorry, I'll ask my question by Arabic for Dr. Mansour and Dr. Mohammed. بالنسبة للتطعيمات الشنغرينج في المراكز الرعاية الصحية، حقيقة أنا كان لي تجربة في مراكز الرعاية الصحية في جدة، مرة مع الوالد ومرة معايا أنا. المراكز الصحية في جدة ما أقدر أتكلم عن باقي المراكز الصحية، عندهم التطعيمات موجودة. اللي لاحظته إنه عشان تدخل إحنا اللي جينا نسأل عن التطعيم نفسه، فإلى الآن ماني شايف إنه مراكز الرعاية الصحية الأولية في التابعة لوزارة الصحة على الأقل إنه في التفاعل الكبير في التوعية، إنه لما البيشنتس أو الناس المراجعين يدخلوا المراكز الصحية يلاقوا إنه مثلا في لوحات، في شيء إرشادي، يعطوا awareness للناس، واويرنس للناس مثلا مخاطر المرض، كيفية علاجه وأهمية التطعيم بالنسبة له. فما كان في أي شيء، يعني لولا إنه واحد أنا متابع ويعني مع الموضوع وأخذت الوالد ورحت وعملت له الجرعة الأولى وأنا نفسي أخذت الجرعة الأولى، يمكن ما كنا عرفنا. الآن بين قوسين موجود مجموعة من الإعلانات على السوشيال ميديا وخصوصا على اليوتيوب، توعية للناس، اسأل طبيبك وكذا، بس إلى الآن ما ملاحظ إنه في توعية حقيقية للناس. فما أدري إذا كنت أنا غلطان أو هذا هو الواقع اللي حاصل. فالسؤال طبعا دكتور محمد ودكتور منصور بعد إذنكم.
طيب انا بالنسبه لي يعني بغض النظر على انا يعني على التوعيه اللي حاصله، انا اعتقد انه احنا كميديكال براكتيشنرز we should emphasize on that and we should initiate that discussion with all our patients. I remember Dr. Ashraf in last meeting, he mentioned that in details, and he said we need to talk about vaccination with each single patient, and this is going to help further burden on our medical practice. So I just mentioned the example, like in that patient, that patient if we lift him he's gonna come to you. يعني حيجيك تاني مرة المريض هذا اللي جاء وكان عنده الحزام الناري حياخد أدوية مثبطة للمناعة وحيجيك تاني مرة. فأنا أعتقد إنه من وظيفتنا إحنا كأطباء بغض النظر عن التخصص سواء تخصصي طب أسرة أو تخصصي أمراض معدية لازم نتناقش مع مرضانا في موضوع التطعيمات واللقاحات. ضروري جدا نوعيهم نعمل تسويق وتوعية للمريض عشان في النهاية هذا كله حيعود علينا إحنا بالمنفعة.
صحيح. أستاذ حسن أشكرك جزيل الشكر على هذه المداخلة، حقيقة هي مداخلة ثرية ومهمة أن نقف عليها وقفة تأمل. في نظامنا الصحي الآن وفي النظم العالمية أي مريض معرض للخطر للإصابة بأي مرض وهناك فرصة تداخلية نقدر نقدم له هي عن طريق توعية أو عن طريق تطعيم أو تحصين، ونفقد هذه الفرصة السانحة إنه المريض يدخل المستشفى ويدخل المركز الصحي ويطلع منه من غير ما نعطيله الخدمة، تعتبر فشل وفشل ذريع في النظام الصحي. فإحنا الآن نتحدث عن missed opportunity، هذه فرصة ذهبية سانحة بنضيعها بأيدينا. فهذه نقطة مهمة، وأعتقد هي تداخل ومشاركة جميع الشركاء أصحاب العلاقة بالموضوع، ليس فقط الجهاز الطبي في أطباء، حتى الجهاز الإعلامي اللي أنت تمثله أستاذ حسن لك دور مهم جدا في توعية وتثقيف المجتمع، أفراد وأسر، وليس فقط المجتمع، حتى صناع القرار، إيصال المعلومة الصحيحة المفندة الخالية من الشوائب عن طريق الجمعيات العلمية وعن طريق الهيئات العلمية لإيصال هذا المفهوم بحيث يصنع القرار الصحيح في خدمة المجتمع. فأعتقد كل الجهات اللي هي الطبية وغير الطبية اللي تعنى بالكوربس سوشيال ريسبونسبيلتي عندها خدمة مجتمعية لتقديم خدمة لابد أنها تشارك في فاعلية في هذا الجانب. أشكرك جزيل الشكر.
العفو دكتور أشرف. احنا بالنسبة لنا كإعلاميين عموما بنحاول بقدر المستطاع عن طريق وسائل الإعلام المختلفة سواء كان تي في أو سواء كانت تقليدية أو حتى الحديثة، بس نحتاج من الأطباء منكم كسادة أطباء إنه في ماتيريال، في مادة، خلال من المادة دي احنا نصنع محتوى ونقدر ننشره ونقدر نوزع بين الناس، لأنه فعلا إنه شيء زي مرض الحزام الناري أو أي مرض من الأمراض حقيقة الناس ودهم إنهم يتعرفوا، ودهم إنهم يتعلموا، ودهم إحنا كيف ممكن نقضي على مشكلة حاصلة في المراكز الصحية لوزارة الصحة أو غير وزارة الصحة، ممكن تكون داخلة في عدم إلمام، عدم معرفة، عدم وعي لدى الممارسين الصحيين أو بعض الناس العاملين في القطاع الصحي بأنه أهمية هذا الموضوع عشان أنا أوصله للناس أو للبابليك. فإحنا معاكم دائما.
جزاك الله خير. Thank you so much. طيب, we will close by one question which is very important. As we know that the shingles vaccine is a new vaccine, has been introduced to our community, and the perception of those people who are eligible to have it is still yet not mature yet. So we have something related to vaccine hesitancy. So from your own perspective as an expert, how to tackle this? And I would like to throw the same question to all the audience. Those who have some ideas to contribute to tackle the issues of vaccine hesitancy. So the floor will be open to everyone. Please. Dr. Mohammed.
Well, thank you very much. Vaccine hesitancy is very important topic, and actually we are facing it. We are facing it actually not now. We're facing it since some time. We have seen this one during the COVID even vaccination. So there was a resistance from some communities. I mean, even physicians, they were in the media, they were resisting for vaccination. Vaccine hesitancy, I can say that vaccine, it is the victim of its success. Vaccine is the victim of its success. So whenever that we have seen those, opposing the vaccination, they said, we are not seeing the disease anymore, so why we have to take the vaccine, etc., all of this. There should be some kind of education, I can say, that this is really very important. So this is the duty of all, as thank you very much, Dr. Ashraf, you have just mentioned very important things which around the corporate social responsibility. So every single individual, whether he or she, they are healthcare providers or an institution, they have to exert some efforts in order to develop this kind of knowledge between the community. We have seen in market research, by the way, people, they don't differentiate between hepatitis A, hepatitis B, hepatitis C. They thought that hepatitis B developed to be hepatitis B, developed to be hepatitis C. They didn't differentiate between typhoid and diphtheria because the same name. So this is not their fault, it's our fault. We have to make sure that ensure those people, they link between MMR and autism, as you know, so this is another thing. And vaccine sense is very important topic. If we leave it like this, God forbid, we'll reach a stage where we cannot vaccinate, and diseases which has been controlled or has been in the past, like for example, the smallpox will re-emerge again, and we have seen it.
Thank you.
Yeah.
Dr. Mohammed?
أعتقد sometimes we need to show them the facts after, like, what is the impact of not taking the vaccine. Like at the end, in COVID, we did that. And I remember when I was in US in about like 3 years ago, the anti-vaxxers population, like they raises there, and they were like strongly against MMR.
Yeah.
And in Texas state, they were saying like, it's an optional if you want to like take the MMR for your kids or not. And their kids is like with the other kids that they are immunized. And an outbreak happened there. And now they saw like an outbreak of measles. Imagine that.
Yeah.
For long years, we didn't hear about it even. And now when they heard about it, the government changed the rule, and now people, they start to get the vaccine again.
Absolutely.
So sometimes you need to show them the facts, and you need to show them
That's
the
right.
complication, unfortunately.
Yeah. In fact, vaccine hesitancy is one of the challenging consultation in family medicine practice. And usually we have to listen to the patient why he's hesitant. Knowing why, you can tackle the root cause and change the perception of the patients, and then show him the benefits and tackle the false belief about the side effect and others. Dr. Hussein, your input on this vaccine hesitancy, we'll take 2 and then we'll close inshallah immediately.
Thank you very much, Dr. Ashraf, and the great panel of speakers here. So just being in the same shoes as all of us here, clinicians, healthcare providers who deal with the community, I think being a clinician in clinic holds you responsible to act as a messenger.
Yeah.
From what we have heard today, to cascade this down to anyone in that institution.
Yeah.
And that slowly will generate a motivation to normalize this, foreign vaccine. With time, things get, normalized. And this is where there are many techniques, and I will just say that if you're going to think out of the box, especially in this techno-savvy community, one of the things that helped with outreach programs in vaccination during the COVID pandemic was, linking it to the, let's say, not to name any companies, but those who were transportation facilities, the food delivery facilities. These can actually help, send you food and get your vaccine along with it. So such things we should all try to engage in. Either pharma companies to support it, or big thought leaders and pharmaceuticals or different institutions. So I'm just saying that I think we all have a role in it.
Okay.
There is no one responsible
Excellent.
person. Thank you.
Anyone else would like to contribute? Dr. Abdelhamid, and then Dr. Hiba.
Thank you very much. I think if we are talking about success stories, it will be very good. The number one story Dr. Ashraf mentioned, it is one of the most important 3 human invention is vaccination. The second success story of smallpox, of polio eradication. All these success stories will give support to more patient persons getting the vaccine.
Okay.
Thank you.
Thank you. Dr. Amira, how to tackle the vaccine hesitancy? This is a question in the Saudi board exam. Okay.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to firstly thank all of you and speakers in specific. To be honest, Dr. Ashraf, from my perspective, it's all about counseling and proper counseling techniques to try to convince the patients to go ahead, as you always show us in the clinic and other doctors along with us in the family clinic, especially in the IMC. It's all about the counseling, giving time to the patient, hearing their opinions, showing facts, comparing the advantages versus disadvantages in general and in specific. Thank you
Okay.
very much.
All right, I think this is, comes to the end of our session, and with this, I would like to thank you for attending with us physically, and I would like to thank our attendees who attended virtually. On your behalf, ladies and gentlemen, dear colleagues, I would like to thank our guest speaker, Dr. Wael Bajahoun, Dr. Mohammed Samanoudi, Dr. Mansour, for their wonderful contributions to enrich the scientific event with a lot of data, a lot of trials and expertise. And I would like to extend my thanks to the Saudi Society for Family and Community Medicine, the International Medical Center, GSK, for sponsoring this event. And a big thanks goes to the organizer, FEXS, for their wonderful organization. With this, I would like to thank you for attending, and stay tuned for another session of IMC Family Medicine Club. Wish you all the best and have a wonderful night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Recording stopped.